Assalamualaikum warahmatullahi wabarakatuh. We are from group LILIS and we will present about leprosy disease. Leprosy disease is caused by Mycobacterium leprae and Mycobacterium lepromatosis. For the pathophysiology, leprosy is transmitted by transmission from a patient to healthy people. The transmissions of mucus or skin lesion through these three ways is physical contact, which is skin or skin lesion surface when people touch it, by nuclei in droplet through upper respiratory tract, whether in air or mucus when patients sniff, and through placenta and breast milk by a mother to infants. Through this, the bacteria can spread in the body and infect the body system. Apart from that, a bacteria also attack immune systems and create immune response that associate with leprosy reaction. Also to say that human genetics actually favors leprosy infections. The cells that are involved are Schwann cells, T cells, B lymphocytes, and macrophages. All are the cells that protect the body from invasion of stranger cells. This immune response can lead to signs and symptoms that will be mentioned in clinical manifestation later on. Leprosy response lists into two types, type 1 and type 2, that show changes in immune systems. The reaction is associated with immune response. Other than that, these are the risk factors that people may be exposed to the bacteria at higher risk. Number 1 is people living in poor facilities, dirty water, insufficient bed, and people with immune disease. Hence, all these are connected. Now, we move to clinical manifestation. In this part, clinical manifestation is categorized based on the classification of leprosy. There are two classification systems of leprosy, which are WHO and Ridley-Joplin. Based on WHO classification, clinical features are given in general in the 8th report of WHO Expert Committee on Leprosy. The features are reddish or pale patches, feel unpleasant and hurt at the nerve, swelling of earlobe or face, and alopecia. Sometimes, in rare case, also cause face paralysis. As leprosy attacks our immune system, clinical manifestation based on Ridley-Joplin system would be easier as it has a broad spectrum. In Ridley-Joplin classification, there are 6 forms of leprosy, excluding the indeterminate leprosy. In indeterminate leprosy, there is no significant clinical manifestation as it is at the earliest stage of leprosy and difficult to diagnose. However, in some people, they may experience the loss of thermosensitivity on the patches. Next, in the tuberculoid leprosy, the clinical presentment of the patches is it has an elevated margin, obvious border. It is either hypopigmented or erythematous. The patches are also symmetrically distributed and the surface of the patches is a bit scaly. It will lead to decreased sweating and loss of sensation and hair at the patches area. Next, we have the lepromatous leprosy. In lepromatous leprosy, the patches look like leonine faces in which the cushion-like lesion is symmetrically distributed. Loss of eyebrows and eyelashes is also a typical clinical manifestation of lepromatous leprosy. Last but not least, in this classification, the borderline leprosy is classified into 3 subgroups. So, the clinical manifestations is also divided according to the subgroup. The first subgroup is borderline tuberculoid, where the patches have more lesions, well-bounded, and less hard compared to tuberculoid leprosy. In this form, the patches commonly have the finger-like extensions. Then, the patch surface also looks dry and scaly. The second subgroup is borderline lepromatous, where the patches are multiple, purely demarcated, and have hypopigmented papules, nodules, and infiltrated plaques. The patches are also symmetrically distributed and they do not have a definite pattern. Lastly, the borderline form of leprosy. In this form, the patches have a well-demarcated punch-out inner margin and a sloping outer margin in the shape of circular plug, so it looks like Swiss cheese. The surface of the patches also dry, scaly, and slightly shiny. Last but not least, there are different types of drugs for treatment of leprosy. The drugs that are used to treat this kind of disease is to make sure that permanent damage to the nerve or muscle is avoided. As we can see in the green cloud, there are 3 first-line drugs that are used for the treatment of leprosy, which are commonly known as dapsone, rifampicin, and clofazimine. These anti-leprosy drugs are based on the WHO standardized regimen. These drugs are also known as multi-drug therapy (MDT), which means they are used either in combination with 2 drugs or in combination with all of these 3 drugs. Multi-drug therapy is the most recommended option and must be used to treat leprosy because when only one drug is used to treat this disease, there may be resistant to drug towards the disease. It enabled the cure of patients, even those with MDT element tolerance. The first drug is known as dapsone, or the other name is sulfone, or also known as diminafonyl sulfone (DDS). Dapsone must be used in conjunction with other antibiotics because it is bacteriostatic. The second drug that is used for MDT is rifampin, which is the semi-synthetic derivative of rifamycin B. This medication is also known as rifampicin (RMP). The main action of this drug is to exert its bactericidal action. Next, clofazimine. It's a lipid-soluble riminorphenazine with antimicrobacterial effects. Clofazimine is only slightly bactericidal against M. leprae. This drug is also good at reducing type 2 reactions in patients with multibacillary infections because it is a steroid agent and has anti-inflammatory effect. There are also alternative treatments for leprosy disease, which are macrolides, fluoroquinolones, tetracycline, and chemoprophylaxis, and also anti-inflammatory treatments for the disease. And they are called corticosteroids in leprosy, steroids in leprosy reaction, and steroids in acute and chronic neuritis. Fluoroquinolones contain a strong bactericidal agent and have been demonstrated to inhibit Mycobacterium leprae DNA gyrase at dose comparable to those inactivating Mycobacterium tuberculosis gyrase. Macrolides has a bactericidal effect against Mycobacterium leprae. Next, tetracycline, which it can suppress protein synthesis. Then, the study of post-exposure chemoprophylaxis with single-dose rifampin is perhaps the most active area of current research in leprosy therapy. For anti-inflammatory treatment, corticosteroids are usually used because they play the most vital role, which features anti-inflammatory and immunosuppressive properties. Lastly, steroids are used in leprosy reactions and also for acute chronic neuritis. I think that's all from us. Thank you.